Good evening, dear friends. Good evening, dear colleagues. It's Wednesday, and Wednesday means ESGE webinar. So welcome here. This is the fourth part of the Back to the Basics ESGE webinar series. And in the next 1 hour, we'll go through a very interesting topic, this of endoscopic ultrasound. It's my pleasure and honor to share the panel tonight with two friends, two experts on the field that will guide us through our topic. I would like to introduce Katarzyna Pawlak from the Center of Therapeutic Endoscopy and Endoscopic Oncology from the University of Toronto in Canada. Kasia, nice to have you here. And of course, I would like to introduce Professor Schalk van der Merwe from the University of Leuven in Belgium. Professor van der Merwe, thank you for being with us tonight. I think that Kasia will take the floor. She will guide us through the role of radial endoscopy in staging, and then Professor Schalk van der Merwe will go through the role of especially linear ultrasound for hepatobiliary and pancreatic diseases. So Kasia, if you're ready, the floor is yours.
Thank you so much, Paris, for this kind introduction. Like always, a great pleasure to me to be part of the ESGE webinar series. And this time I have a pleasure to talk a little bit about performance of structural radial EUS staging, about tips, about also some limitations, because like every tool is not perfect. So this is my competing interest disclosure. And I hope that by the end of this interactive session, attendees will be able to meet indications for EUS staging, what is extremely important in the light of current ESGE guidelines. And also, you will be able to meet crucial steps for radial EUS staging in luminal GA cancers. So I think this is the most typical scenario we have in our daily practice. Patients are referred to us already with perform diagnostic workup. So patient underwent in other institution endoscopy with biopsy, which confirmed adenocarcinoma, let's say, of esophagus, and then referring physician performed already CT of the chest, abdomen. In other terms of other cancers, they will also perform sometimes MRI. And metastatic disease was excluded, so that the patient was referred also for PET assessment, and then also disseminated disease was excluded. So we have literally located tumor in one place, so let's say in esophagus, and then the patient is referred to us to perform EUS. And why we do that? Because we want to see what's the extent of local regional disease, and also because there is some uncertainty about the depth of involvement, which is important in terms of removal of the lesion. And we can ask also why EUS is better than other imaging methods, and actually it's not better in terms of all spectrum assessment, but for particular one like a local regional assessment, so T features, so staging of the tumor, the studies show up that EUS was even up to 6 times better in terms of accuracy than the rest of imaging techniques. And it's changed the therapeutic management in about even 30% of selected cases when we had a T1 or T3 feature. However, this is only complementary tool, so patient has already performed other workup, because some other techniques will be better, for example, in estimating if there is any metastatic disease. So that's the question, if patient is referred, so how we should provide structural radial assessment of the lesion. And I think the structure, to me at least, it's easy to remember. My assessment will be according to TNM classification. So first, I will start with the assessment of the tumor. Then I will look at the local lymph nodes. And if possible, I will check if there are any other possible metastases, for example, to lateral liver lobe. And you can see here what's the range of EUS scope. So we can see with EUS quite a lot. In terms of gastric and esophageal cancer staging, we can first of all see a lot in terms of T features, so actually entire assessment. Then, as I mentioned before, look at the lymph nodes if there are any visible. And of course, we can take a look of eventual sites of metastasis. However, when it comes to the rectum, the situation looks a little bit different. Of course, we are assessing T feature first of all, and then we take a look on particular local regional lymph nodes. Of course, we are not able to see the distant metastatic disease in the situation. And we can also ask what's actually the sensitivity and specificity of EUS in terms of T-staging assessment. So we can see here that it's quite good. So it's from 80 up to 90, even 8%, depending, of course, on studies for esophageal cancer, gastric cancer, and rectal cancer. And sensitivity and specificity obviously will be growing up with the T feature. So if we'll be having more advanced tumor, then obviously our sensitivity and specificity to determine the lesion will be much, much higher. And then we can ask why actually we should pick up the radial scope, like we have also linear scope and mini probes, which are showing different things. Obviously, it depends on the center and the thing you've learned, but because we're talking about the radial scope, I would like to show you what are the advantages of radial EUS. Obviously, we will be able to perform different scanning. So with radial scope, the scanning angulation will be 360 degrees, and this will provide us better overview of the gastrointestinal wall and paramoral structures. And also, we will be able to see 100% of visceral circumference in a single view. So we don't need to maneuver so much, and assessment might be much more comfortable than with other different probes. Of course, we use the standard settings of frequency. So for this frequency, we'll be able to see the up to from 3 to 5 centimeters in depth, and this will provide better assessment for extramural anatomy with locoregional staging of advanced lesions, and obviously also for lesions bigger than 20 millimeters in size even. So we know that we pick up the radial scope. So now how to actually provide the performance of EUS radial staging. And this is the classic EUS radial scope. You can see that's the tip of the scope, and on the first picture you see the tip of the scope without the balloon. Then you see on the second one with adjusted balloon. I strongly encourage you to use the balloon for radial scope because it will enhance our assessment. And before we advance our scope, we have to check if the balloon is working. So obviously we're insufflating the water. We are checking up how the balloon is working, if it's working properly or not. I will come back to the slide to show you up. And aside of that, if we will check if the balloon is not working or not, I can ask David to show it up maybe again, the previous one. Yeah. So we are inflating the water, then we are desufflating so we can see how it works. And obviously at the same time, we are able to see on the second screen and the sonographic screen if it's working properly. It's important because sometimes you can have a hole in the balloon, you can have some leakage. It might be related with many different technical aspects. So you can change at the same time the balloon on the scope. You can put the new one. You can also exchange your buttons because sometimes the buttons on the scope are the cause why the balloon is leaking. So you have to check that because during the examination, then you'll be frustrated that you cannot provide sufficient assessment because balloon is not working. So I strongly encourage you to check that before. And even before we go with EUS, I think the most proper thing is to perform our own assessment by EGD because patients are referred from different centers. Sometimes the assessment is not like we would like to have this. And I think it's important in many different aspects and also according to EEG guidelines that this will be dedicating if we should perform EUS or not. Because first of all, we have to see where the lesion is located. Then we're supposed to assess lesion very meticulously in terms of size, morphology, and Paris classification. What is the margin of delineation and what is the estimated depth of invasion? Because based on that, we will refer a patient and we will perform EUS. But also it's important to, of course, remind the location because if we decide to perform EUS, then it's easier to find the lesion. But on the other thing, we will be able to see if there are other abnormalities. So if there's any structure, for example, and if we will be able to perform EUS assessment or not. And I think this will be the safest for the patient to check that. So we advance our probe and what we should look for. So the first step, I think, in terms of radial EUS assessment is to checking what's normal if we want to determine what's abnormal. And this is, I think, basic view from the radial EUS. we have to see what is the appearance of normal wall layers above or below the lesion. And it's typical standard view. We always have 5 layers, and by this, we will memorize the layers appearance and we'll be able to estimate what's actually the location of the lesion in GI tract wall. And you always have to remember that muscles will be black, so depth part of the mucosa, so muscularis mucosa, will be dark, obviously, on the screen, and same for the 4th layer, which is muscularis propria, which also will be dark black. And as you can see here, these layers will determine T stage of the tumor and will tell us more about the advancement of the disease. So we know how looks the normal wall. We found our lesion, but we also have to keep in mind what to expect, what to expect, and what to look for. And more or less, all lesions in GI tract will look the same in terms of cancer. These lesions will be echo-poor, rather sometimes can be also like inhomogeneous wall thickening, depending on the location. But always we will have that disrupting the normal 5-layer structure of the GI tract wall. Depending also on the location and tumor type, lesions might be more localized or more diffuse. However, always we should look for involvement of deeper layers if the lesion is going outside of the wall, or maybe we have eventual infiltration into other structures. So we know, of course, now how looks the normal layer, how lesion looks like. So we have to then think about our T features. So if you can look here, we have particular different 4 types of tumors. I didn't include T1A, T1B for esophageal and gastric cancer, but this is assessment of esophageal cancer, and you can see that T1 feature, we will call it when we will have infiltration into submucosal layer, but the lesion will not go beyond the submucosal layer, so actually beyond the 3rd layer. When it comes to T2 feature, our lesion will be growing into muscularis propria, so the 2nd black layer, however, still will be not crossing beyond the 4th layer, so beyond the muscularis propria. Then we have T3 feature. So when our lesion is invading into subserosa or pericolic fat in the rectum, however, still not going deeper. And T4, the most advanced lesion, when the lesion is invading into surrounding structures, whether we have invasion of peritoneum or liver, spleen, or male or female organs, depending on the tumor location. And I think that's the main question before we proceed with resection. There always is uncertainty if this is T1A or T1B feature. So what's actually the EUS accuracy for distinguishing early versus advanced lesions? We know from studies and from our experience that EUS is useful for lesions with actually differentiating lesions between superficial and very deep invasion. So it's more dedicating for lesions with deep invasion. It's easier to assess them. However, when it comes to the accuracy in distinguishing between T1A and T1B study in daily practice is very, very difficult, and accuracy is dropping down. And also sometimes we know that from studies published so far that endoscopic assessment performed by experts was not worse than EUS assessment in terms of predicting histology, so advancement of the lesion. And sometimes even in some studies they show the assessment performed by advanced endoscopic imaging was better than EUS. So in terms of very early lesions, sometimes we cannot say actually what's the advancement of the disease. So we finish with the assessment of our tumor. We know how advanced the lesion is. Now we have to go to end features, so the local lymph nodes. And again, if we want to see what's abnormal, we have to know how normal lymph nodes looks like. However, there are mainly 4 features for malignant lymph nodes. And if you see that our lymph node has greater than 10 millimeters in size, diameter, but in short axis of lymph node has a round shape, sharp border, is homogeneous and hypoechoic. And if these 3 criteria will be seen on the screen, it may be related to likelihood of metastasis even up to 90%. So we are looking rather for these lymph nodes instead of looking like benign appearance. And that's only to show you up how many different stations you have in terms of gastric cancer. Same is in the mediastinum when you assess esophageal cancer. Of course, it's very difficult to trace them all, but I think we have to check if there are any lymph nodes. So to check more or less if we see any abnormalities. When it comes to the lymph nodes in the rectum for rectal cancer, we start actually assessment from the up. So we advance the scope more or less to the level of rectal sigmoid junction. And then we try to pull back the probe and see if there we see any lymph nodes. Because actually in terms of rectal cancer, we don't see lymph nodes normally in perirectal region. So if some lymph nodes will be assessed, we then should assess them more meticulous in terms of malignancy. So we assessed our lesion, we know that there are some lymph nodes or not, then we should provide also a little bit of assessment in terms of metastatic disease. Why? Because sometimes some lesion might be missed by other imaging techniques, like for example, CT scan. So we're supposed to check if there is any, if there are any changes in left liver lobe, if there are any changes in peritoneum, if there are any changes in mediastinum or pleural layers of the lung. And if we finish our assessment, we can also talk a little bit about technical aspects and how to enhance assessment by radial EUS. So depending, of course, on the location, if you have the lesion located in esophagus or stomach, we start our assessment below the lesion, so we are pulling back slowly. And when it comes to the rectum, using water, so filling the lumen with water may be very helpful in assessment, especially for this occasion, but also changing the patient position might allow for easy submersion in water and then evaluating the location in the rectal wall. What's also important is that we try to keep the probe in the middle of the lumen of GE tract. We rather try to avoid pressing on the lesion to not lead to overstage or misinterpret the advancement of the disease. And before we start filling up our balloon, I think it's good to remove the air from the lumen. And sometimes we can fill out the lumen with water using 60 cc of standard syringe. We rather also try to avoid filling our balloon or lumen oval, so the solutions containing simeticon, because it can cause and it can provide cloudy views, so will be much more difficult to assess. And another thing is always the question if we should use the balloon or not. As I mentioned before, it's easier to assess with the balloon because balloon will eliminate air pockets between transducer and GA wall, as you can see on the pictures. We only use the balloon slightly distended, and we are filling out the balloon with water. In the beginning, we use a little bit suction to remove the suction from the rest of the balloon. And assessment always should be very slow movements back and forth. Sometimes we also just stand at the site of the lesion because reading movements will anyway provide another assessment. And this is the checklist which might be helpful for your EUS, radial EUS staging evaluation on GA tract cancer. So I rather start from the tumor assessment. The order doesn't matter actually, but it's important to keep some order. By assessment or after assessment of the tumor, I am going to assess regional lymph nodes and metastatic eventual lymph nodes. And I'm assessing metastatic disease in left liver lobe, peritoneum, because we can have low volume acid not seen by any other imaging techniques. Also pleural lining and mediastinum to see if there's any metastatic spread disease to lymph nodes as well. Of course, for particular cancer, it's different. And whether finally the limitation of radial EUS staging, it's important to emphasize that actually radial EUS assessment for staging is not so obvious sometimes, especially in terms of particular locations like cardia, fundus, gastric angle. Lesser curvature also might be difficult, and pyloric channel, because this may cause under or over staging, what is extremely important for the patient. That's why we first assess endoscopically and then we qualify for a EUS eventual assessment. Also, under and overstaging might be related with early lesions without deep invasion. That's why we rather assess lesion more advanced. Also, when we have tumors with peritumoral inflammation, this also can lead to overstaging, especially when we have ulcerated cancers. And location, as I mentioned before, but also size, and according to ESGE guidelines, depth of the lesion. So infiltration into GA wall layer may can cause to particular percentage around 30% of over understaging, and lesion type obviously also. So I rather encourage you to go to ESGE guidelines to see how it really looks like. And this is just example what our guidelines are showing up for esophageal squamous cancer. You can see that, and also for Barrett's esophagus cancer and for colorectal lesions, we rather perform EUS when we have deep submucosal invasion, and for gastric cancer, actually, we don't use EUS so frequently. So that's the question to Paris and Professor van der Merwe. How the lesion should be removed, and if the lesion can be removed endoscopically or not. So that's the typical appearance of GI wall layers. We can see our lesion located just here, and I hope you don't see it clearly, because I see just like a little bit broken image, but the lesion is quite well visible. And you can see how it's located in esophageal wall, because actually that's the distal esophageal lesion located going more into cardia. So assessment very difficult. However, it's clearly seen that the lesion is going beyond particular layer. So I want to ask Paris and Professor van der Merwe then, maybe after the session, after the presentation, what type of lesion is that, if it might be assessed or referred for endoscopic resection. But aside of that, you can see that balloon is not distended so much. And also the air was removed as much as possible. I also fill out the lumen with the water because the location was difficult. And after even this assessment, I try to assess also the left liver lobe and also lymph nodes at this location, if there were any visible or not. But this is nicely seen now how lesion is advanced in this situation. And we can go, I think, to the second video. That's the endoscopic appearance. The lesion was potentially qualified for resection. So you can also see how lesion looks like and if it should be endoscopically resected or not. This is SCC cancer. Not so well seen in endoscopic appearance, but in NBI will be definitely more visible. I think SCC is the most difficult to assess, especially when lesions are early. And you can see the lesions here, and then you can see how it looks like in NBI, that the lesion is actually infiltrating 50% of circumference of the esophageal lumen. And then we provided an EUS assessment for this lesion. It's a little bit different than the previous one because we have something extra, and you can see on the screen actually. Lesion is visible here, and you can see also how it looks like when we take a look on particular layers, especially muscularis propria layer. And then we can take a look also on serosal layer. Also, additional things are visible on the screen. So we can think if the lesion, also based on these additional abnormalities, we can determine if the lesion could be potentially removed by ESD or not. Okay, so with the end of this lecture, I will ask Paris and Professor van der Merwe, but I would like to give you a summary on this presentation that EUS still is important in terms of local regional tumor staging assessment for particular GI lumen cancers, remains as a complementary tool to other imaging techniques. And I think if we want to provide complete EUS assessment, if we will provide EUS, then we're supposed to also assess eventual lymph nodes and metastases. But what's also important that EGD also should be performed, because EGD will deliver information if EUS is indicated or not. So that's it. Thank you so much for your attention. I hope that was useful.
Thank you so much, Kasia. I think I saw some lymph nodes in the second video.
Yeah, exactly.
And for the first one, I think it's a T3. It seems to invade the muscularis propria. Is that right?
Exactly.
So none of them was a good candidate for endoscopic resection. Yeah. Okay. Thank you so much, Cassie. I think we have a couple of questions for you, but I think it will be better to collect all of them and discuss together with Professor van der Merwe at the end of his lecture, if you are okay with that. So that said, I will give the floor to Professor Schalk van der Merwe for his presentation regarding the role of linear EUS in hepatobiliary and pancreatic diseases. Please.
Thank you so much, Paris, for the introduction. And I think this has become a very important forum to share information, and it's good to see so many people online. It will be a hard act to follow. It was an excellent lecture, but let's try. So the objectives of my talk will be to convince you of the importance of a very systematic evaluation when performing a diagnostic linear EUS. The importance of identifying the anatomical landmarks in a systematic way that will take you from the one to the other, so that lesions are not missed because you skip and you omit to really do this in a systematic way. And of course, the use of the anatomy to determine access routes in therapeutic EUS will also be discussed. So I don't have to preach to the converted when I say that endoscopic ultrasound has really revolutionized the field. Both diagnostic and therapeutic EUS now forms part of the armamentarium of the endoscopist that he can offer to manage patients better. With EUS, we can access previously inaccessible regions of the gastrointestinal tract, and by placing the echoendoscope in close proximity, we can visualize structures like bile ducts, the pancreas, the liver, the gallbladder, in order to perform diagnostic and therapeutic procedures. So linear EUS may be used as a diagnostic tool. I think it has become more and more the diagnostic modality of choice, as it can commonly be combined with if there is a need for acquiring tissue. So instead of using both radial and linear, many centers have now switched to linear EUS to perform both the diagnostic and the therapeutic investigation. So with linear EUS, the endoscopist wants to evaluate the anatomy. She wants to identify suspected lesions. It is also important to characterize the abnormalities in some settings, for instance, in patients with chronic pancreatitis. And often there would be the intention of acquiring tissue for a tissue diagnosis. And this can be combined when using linear EUS. So the investigation in linear EUS really starts from identifying the anatomical landmarks. Often we would start from the abdominal aorta, where we would localize the celiac artery. And then by pushing the scope slightly forward, we would identify the splenic vein. That can then be followed by gently rotating the endoscope anti-clockwise to identify the portal vein, the pancreas neck, pancreatic duct, and the intrapancreatic course of the bile duct. Whereas if you rotate the scope gently clockwise, it brings into view the pancreatic body and tail until you reach the spleen. On the duodenal bulb, that's a very important next anatomical position, where you can identify anatomical landmarks, including the pancreatic head, especially the uncinate process. The distal common bile duct and the pancreatic duct, as well as the gallbladder, can often be seen from this position. And then from the second or third part of the duodenum, we can see the pancreatic head, especially visualizing the ampulla in great detail. So in this video, I hope to illustrate this. You can see the abdominal aorta with a celiac takeoff. I'm now pushing the endoscope gently forward, identifying the splenic vessels. And by rotating anti-clockwise, I can follow the splenic vein until it reaches the confluence at the portal vein. And now the area around the confluence will become more clear, the pancreatic head. And here we can see the structures, including the pancreatic duct, the bile duct coursing through the head and neck of the pancreas towards the liver. And this is a very important anatomical landmark, because if you see this, it tells you, gives you a lot of information. By now rotating clockwise, it brings into view the body and the tail of the pancreas. We just passed a small cystic lesion. And by rotating further, we pass the kidney as well as the adrenal gland on our way to finally finish when we visualize the hilum of the spleen. So this is a very important movement, because by this movement, you can really in one sweep see the whole structure of the pancreas without interruption. And I think this is very important. You don't want to interrupt. The images must sort of flow as a movie. There you can see the adrenal gland, and this is also a quality measure. When I train the fellows, I think visualizing the left adrenal gland is a quality measure, because it shows you that you have adequately visualized the most posterior aspect of the pancreas in your examination. So the next anatomical location that we would want to aim for is from the duodenal bulb. And what you can see here is that it's actually easy to recognize the bile duct, pancreatic duct, as it courses up to the level of the small bowel. And now we can follow the bile duct back by gentle rotation. You can see this bile duct is not dilated yet. It's still easy to see with it in close proximity to the transducer, and we can follow it up to the level of the hepatic hilum next to the portal vein. Now, from the third part of the duodenum, this is also important, because from this side, you can see the Kirkring folds of the duodenum. You can see the pancreatic head, the duodenal fall off. You can see the uncinate process, but by gently pulling back, you will see that we can now identify the anatomical region, the dorsal and ventral pancreas, and the ampulla, and one can very nicely from this position visualize the pancreatic duct, the course of the pancreatic duct, and then follow the pancreatic duct all the way towards, as it curls around the portal vein. So again, a very important anatomical landmark, as it shows you the pancreatic head, the uncinate process in more detail, but from a completely different perspective than what you would obtain from either the stomach or from the duodenum. And this certainly gives you added assurance that you have adequately visualized the pancreas head from at least 3 positions. Now, I like to compare an EUS examination to this image. In the first place, this image will, we can compare this image to a well-performed EUS, where the endoscopist must first visualize the abnormality, in this case, the head of a cat is seen amongst the grass. So I think the first objective is for the endoscopist during training to recognize what is normal and to recognize what stands out from the normal background, and to identify that as the abnormality. Fortunately, in most cancers, the abnormality will be recognized as a hypoechoic structure against a more hyperechoic background. I think the second important aspect is for the endoscopist to then characterize this lesion, to characterize and to see to what extent this lesion extends into the surroundings. And then the third aspect that is important is, as you gain more experience, you would recognize this lesion, and you will be able to characterize it and give it a name. In this case, this is not a leopard or a lion, but this is a cheetah in the long grass. With EUS, we also have certain features of the EUS process itself that we can utilize to enhance. For instance, contrast harmonic imaging or giving contrast will help to enhance. In this case, you see what appears like a leaf, but by enhancing this, and this will be analogous to what can be done by using the processor and using your scope effectively, the lesion, in this case, the gecko, stands out from the surrounding structure. So I will implore everyone doing EUS to really sit down with their supplier, be it Pentax, Olympus, Fuji, or Loka, and really sit down with them to identify what is the best settings so that you can always have default settings that you can use in order to identify your pathology with greater certainty. In this case, I actually want to highlight three important issues. The first is that when you start training, you should be able to very quickly recognize this hypoechoic structure. This is now the EUS, linear EUS scope placed in the duodenal bulb. We're looking at the pancreas, and it's fairly easy to recognize that there is a hypoechoic structure within the more hyperechoic background of the pancreas with some tumoral vessels. So I think the first tier, the first layer of investigation should be for the junior person to recognize this. However, if you look carefully, the more experienced endoscopists will see that there's no pancreas tissue appearing between the transducer and this lesion. So that may suggest this lesion is originating from the duodenal wall rather from the pancreas itself. The second thing that I want to show is that the remarkable comparison between the echoendoscopic image and the post-surgical resection specimen. So what you're seeing there is the duodenal lumen over there. This is the lesion that we could recognize there. And this is the pancreas tissue that we can recognize there. But the incredible clarity that this image already provided can now be found back in the resection specimen. And what was very clear from the resection specimen, that this tumor did indeed originate from the muscularis propria. This was an exophytic growth of a GIST tumor that could have been anticipated by careful examination of the echoendoscopic view. This is another example where our EUS correlates with the post-surgical specimen. In this case, you can see a serous cyst adenoma with a microcystic aspect that can be confirmed in the resection specimen. You may ask, why was this lesion resected? But it was resected because we also found another lesion, a carcinoid tumor, and that led to the resection. The lesion was not, the cystic lesion was not resected per se. Now, it's not always that easy. Sometimes it may be more difficult, as should be illustrated in this case, where one can see the hyperechoic aspect, but also the normal, more hyperechoic aspect of the pancreas. But I want you to carefully focus on the blood vessels, because the blood vessels contrast well with a more hypoechoic lesion, and this helps you to identify the abnormality and where you would then aim your EUS FNA needle at. So there the FNA needle is localized, the lesion is localized, the FNA needle can be used more accurately to target that zone that may not have been as easily visible. EUS is also superior to MRI or CT when small lesions are sought. In this case, a patient with severe hypoglycemic attacks, where MRI, CT, as well as nuclear imaging, those studies were all negative. But by using EUS, we could identify a hypoechoic lesion in the pancreatic head, that is a pancreatic duct. In this case, clearly in the clinical context, an insulinoma, and the patient could be sent to surgery without the need for further EUS FNA. So if that is the case for the use of linear EUS in diagnostics, how should we approach the use of linear EUS in therapeutic EUS? Well, I think the objective may be slightly different, because in therapeutic EUS, the endoscopist wants to evaluate the anatomy with the intention to provide therapy, be it therapy of the bile duct, the gallbladder, pancreatic drainage, or fluid collections. So the objective is slightly different. And there the aim is not specifically to evaluate the anatomy completely, but it also brings with it specific information that you need to seek, and it is important that the endoscopist be aware of the anatomy in this setting. Very often we would perform therapeutic EUS in dedicated endoscopic suites, where not only EUS is available, but also careful management under anesthesia, and also the use of fluoroscopies, because these procedures are often combined. and there is a need to do this in specialized units. In this case, the most important or the most common use of therapeutic linear endoscopy is for the drainage of fluid collections. And I would also suggest that in your training that you start off, because these are fairly easy to do. To recognize large fluid collections may not always be that difficult, and it's always a good start to hone your therapeutic skills when you need to drain these collections and identify fluid as well as necrosis, and then choose the most appropriate therapy. Because as very often is the case with therapeutic EUS, EUS provides a conduit and access to a collection or to a duct, which can then be managed in a different way. So in this case, EUS was utilized to create a conduit, an opening through which stents can be accessed into a collection that walled off a necrosis collection that became infected. And this allows then also in subsequent sessions to use this conduit in order to perform therapy, in this case, removing pancreas necrosis endoscopically. But the procedure started off with EUS creating access, and then subsequent procedures, endoscopic procedures, then cleared the drainage, cleared the necrosis from the collection. So what about the use of therapeutic linear EUS in the management of biliary system, or biliary pathology? I think in this case, it is important to recognize that, as I said, the intention is different. Here, we want to localize dilated ducts with the intention of inserting a needle into the duct and then performing therapy. So in this case, we identify a dilated duct from the proximal stomach, a dilated bile duct, segment 2 duct from the proximal stomach, and we can now use the EUS guided 19-gauge needle guided into the dilated duct. As soon as that is done, it may be advisable to aspirate, may confirm that you're in the duct, and then contrast can be injected to identify the anatomy, and then to proceed advancing guide-wise for endoscopic therapy. Again, here, therapeutic EUS is the gateway, provides access, and the rest of the procedure done at the same time will be guided by your fluoroscopic image. So in this case, the EUS scope is positioned in the proximal stomach. We've accessed a dilated bile duct in the left liver lobe. We've now advanced the guide wire past the stricture and the stenosis. We can identify the malignant stenosis. This is in the case where ERCP failed. The guide wire is advanced into the small bowel, and now the procedure can be done in an antegrade fashion for placement of a stent. As shown here, the stent is advanced past the stenosis and then is deployed in the small bowel all through the initial access using endoscopic ultrasound. Endoscopic ultrasound has also revolutionized the management of biliary pathology in patients undergoing Roux-en-Y gastric bypass. In this case, the EUS is used because of the fact that these patients we cannot access the papilla in the normal conventional way. The use of echoendoscopy is advantageous because we can reconnect the excluded stomach to the pouch stomach through the placement of a stent, which now allows this to be used as a conduit, advancing a duodenoscope up to the level of the papilla for therapy. Also known as the EDGE technique, endoscopic ultrasound directed transgastric ERCP. The principle of this is, again, the endoscopist needs to recognize the anatomy. In this case, the excluded stomach can normally be recognized quite easily by rotating the endoscope to face laterally, identifying the folds of the stomach, and then using a 19-gauge needle under EUS guidance. Fluid is inserted into the excluded stomach for finally the placement of a lumen opposing metal stent, as shown here, that will serve as a conduit for your ERCP procedure. So the placement of the lumen opposing metal stent is then followed by dilation of the lumen that will allow the duodenoscope to be passed through the scope. Normally we would do the ERCP in the same procedure. We would we would make sure that the stent does not migrate by using clips, and then the duodenoscope can be passed through the lumen opposing metal stent, and a normal ERCP can be performed. And I think a wonderful procedure that has really revolutionized the management of stone disease following gastric bypass surgery. What about the management of therapeutic EUS in pancreatic disease? Well, in this case, again, the EUS scope is used to access a dilated pancreatic duct in cases where a retrograde access to the pancreatic duct is not possible. And by advancing the catheter into the duct and finally advancing the guide wire through the obstructive pancreatic duct segment, a rendezvous procedure can now be performed. And this, I think, is very important, because if you look at the studies where surgery was superior to endoscopic therapy in patients with chronic pancreatitis, in those studies, endoscopic management failed in up to 62% of patients. So in 62% of patients, endoscopic access to the pancreatic duct via the retrograde route was not possible. But now with EUS, we should be able to overcome this. And again, EUS will serve as an access procedure, because in the next step, we can perform, now that we've got ductal access, we can perform intraductal therapy using spyglass. In this case, this was not possible with ERCP before the development of spyglass. It was very difficult to manage these stones in some patients, and now we can achieve complete ductal clearance. And I think the management of complex chronic pancreatitis will change if we can confirm that ERCP with complete ductal access following access by EUS can be obtained and is at least comparable to the outcomes achieved with surgery. And then finally, therapeutic EUS in the management of gastric outlet, malignant gastric outlet obstruction. This has also revolutionized this therapy. In the past, gastric outlet obstruction was managed by either surgery or by placement of duodenal stents. But now with the development of EUS techniques, we can place a lumen opposing metal stent from the stomach to the small bowel, to the jejunum, circumventing food so that the malignant obstruction is circumvented. Food can now pass into the small bowel, creating a fusion of the layers and a stable fistulous tract that is incredibly useful in this patient population. Again, this is a hybrid procedure, meaning that we combine first gastroscopy with placement of a catheter to fill the jejunal loop past the obstruction. Then by filling the loop, we create a target for placement of a stent. Then, and in the final step, the stent is deployed under EUS guidance to create a opening. And this is what it looks like echoendoscopically. This is the dilated small bowel jejunum that was filled. Finally, we place the axial stent, and now in this view, one can see the lumen through the axial stent, creating the surgical size anastomosis, and these patients are incredibly well served in this way. So, Mr. Chair, in conclusion, I think the basics of successful diagnostic and therapeutic linear EUS examinations really start with the identification of the anatomy. This should be done in a very systematic way, where the landmarks will lead you to the next, so that you build in checkpoints and that you see the complete anatomy in order to identify lesions and not miss lesions. By evaluating the pancreas, for instance, from 3 different vantage points, the stomach, the bulb, and D3, really allows cross-validation of your findings, which again increases your ability to detect small lesions. I think it's important that if you want to learn these skills, that you find an excellent training unit and mentors that will train you in these skills. And finally, I think the aim of therapeutic EUS is to recognize the anatomical landmarks and structures with the aim of providing endoscopic therapy. And this, again, needs specific training, because it also requires you to identify the right anatomical structures in which these therapeutic procedures will be performed. And I think, Paris, I will stop there. Thank you.
Thank you so much, Professor van der Merwe, for this excellent presentation. And thank you for being a key player for the production of the ESGE guidelines about the role of EUS in interventional endoscopy. We have some minutes for discussion. We have a couple of questions for you, for both of you. Kasia, I think that you clearly described the technique that we should follow when we perform a radial EUS. You mentioned that in the rectum, especially, we should not press against the lesion. Could you please explain us why and what are we afraid of?
Yeah, in general, we should avoid to press on the lesion if we're using balloon, or if we perform the assessment with radial or linear scope, because it can cause misinterpretation of the results. So it can cause overstaging or understaging. So that's why we try to keep the probe in the middle and in neutral position, obviously. And like, obviously is like well seen when you try to keep the probe in one position. I know that sometimes it's very, very difficult. So we need to turn our patient, or we need to feel out the lumen, but try to avoid compression, because it will definitely cause misinterpretation of the results.
Exactly. And especially for gastric and esophageal lesions, do you perform a complete radial examination, or you focus just on the lesion? Will you go also check the pancreas, for example?
So you mean assessment of the lesion in the stomach, right?
Yeah, or in the esophagus. Will you also perform a complete radial examination?
So if I have the lesion and the patient is referred for lesion particularly assessment, I do not perform entire assessment of pancreas and entire exam, which is provided in terms of hepatobiliary assessment. So for this particular assessment, I'm focused on TNM classification, and I'm going to assess the lesion, lymph nodes, and eventual metastasis, but I do not perform entire assessments.
Yeah, thank you. And we just have a question from Professor Christodoulou that was also a question that I would like to ask you. In the era of linear EUS, and you know that many centers just have one single probe, and this is a linear probe. Do you see any role of this probe, of linear probe, for the assessment, the staging of subepithelial lesions or esophageal or gastric ulcer, for example?
Yeah, so in my previous center, we did not have a radial scope, and I used only linear scope, and I've never seen any problem with using linear for this assessment, and I've never also used the balloon, so actually for linear scope. So to me, it was not so important. In terms of radial scope, I feel the balloon is very helpful to estimate the lesion. Also, to me, there was no difference if I assess particular lesion, if this is subepithelial lesion. So it depends how you are trained, and it depends how you can maneuver with the scope and on your expertise. But I think it doesn't really matter if radial and linear EUS scope will be used. What's more also important, there are some studies showing that linear scope is not worse than radial scope in staging and in particular lesions assessment. So it's all up to expertise, I think.
And for a gastric fundus, any difference between linear and radial scope?
Yeah, so I think from this perspective now, I would pick up radial scope for gastric fundus instead of linear, because it's definitely more difficult to maneuver, I think, to me at least, with linear probe. So I would go with radial one. And fill out the if possible, gastric fundus fill out with the water. Maybe this will help to assess the lesion then.
And then experience regarding obstructive esophageal lesions, for example, do you perform any radial EUS for obstructive lesions, or they are not referred to you?
So these patients are actually here not referred, but in the previous center we had the slim scope EUS, and sometimes we were preferring evaluation. However, if the lesion is already obstructing lumen of the tract, is probably super advanced, so EUS will not give us any additional information, probably, which would be not given by any other imaging techniques.
I agree, it's at least a T3 at this case. Thank you so much. Thank you so much, Kasia. Thank you so much. Schalk, I don't know if you have any question for Kasia. Any comment?
No, she did it so well. I've got no questions. I think it was
Thank
very
you.
well demonstrated.
Schalk, I was also taught to start from the celiac artery, move forwards to the duodenal bulb, and end my procedure in the second and third part of the duodenum. This is how I learned that in Brussels. But I have seen many colleagues starting vice versa, from the third part of the duodenum and pulling back the scope to the celiac artery. Is there any real difference, or it's just a question of system?
No, absolutely not. I think what I like to train the fellows is doing the procedure always in the same way. So if you do it once from the stomach and once from the small bowel, and I think you start to take shortcuts, and I think that is what you should avoid. A diagnostic procedure should be done in a very systematic way. And as long as you made to devise your own plan and your own landmarks that you follow, it really doesn't matter as long as you do it in a systematic way.
And we have some studies showing that learning to recognize the landmarks around the celiac artery in the head of the pancreas and in the body, the neck of the pancreas is much more easier than recognizing the landmarks in the duodenal bulb and the second part of the duodenum. Do you agree with that from your experience?
Absolutely. I think that it does take time, and therefore people should also practice that, because I've also seen that because it's difficult, that people tend to not to waver too long in that site and want to quickly finish the procedure, and if they don't see it immediately, then they move on. But it's really worthwhile to spend a bit of time finding the common bile duct from the duodenal bulb, following that out. You can see the pancreatic duct beautifully coursing through the pancreatic pancreas in that area. You can see in many cases the common bile duct entering into the small bowel, and sometimes the view is better there, especially if you want to exclude small stones, than what it is from D3. But you're right, I think it does take time. There's no substitute for experience, training, and perseverance. I think if you don't get it right the first or the second time, you have to persevere, and then it's good to have a mentor that shows you what you haven't seen. This is the reason, by small tweaking of the endoscope, small changes in the body position, using your small knob of your endoscope, now suddenly you start to see things. I think what may also be interesting is to use water in the small bowel, especially if you want to look at the ampullary lesion, at ampullary structures, because that also helps you very often to see the anatomical regions better. And in the presence of, for instance, diverticulum, you can, when you install water, it fills the diverticulum, and immediately you know that what you've seen was caused by diverticulum and not due to other pathology. So these tips and tricks, they come with experience, but they should also be taught, and you should also go to units where people take interest in showing you how these procedures should be best performed.
Yeah, I agree. And what about the balloon inflation during linear EUS? Do you use a balloon? Never, sometimes, in some cases?
No, I've never found it helpful. I think that if you use a good technique and you refrain from over insufflating, I think you really do not have any additional benefit by using the balloon. So we never use it.
I have a question from our audience regarding the pancreas visualization. If it is a trick that we can follow in order to improve our results in patients where there's a lot of peripancreatic fat that may hinder our vision. Any comment?
So I think that, of course, anatomical variations do influence your sensitivity and your the way that you can detect lesions. So in the older individual, we know that echogenicity is less than what will be the case in a young individual, and you may also find fatty changes in the pancreas that may make the pancreas more difficult to visualize. What I would normally do under those circumstances is then first look at the pancreatic head because if I then see the pancreatic head well, and I then follow the anatomy backwards towards the body and tail, suddenly I can see those structures more clearly, because I have become used to the anatomy in the pancreatic head. I've become used to the attenuation of the echogenicity in the head. So that's a tip and a trick. But in some instances, it may be difficult, especially if there's a lot of fat in the pancreas, to be absolutely certain. Remember that most lesions, fortunately, will be hypoechoic. So we should still be able to see a hypoechoic lesion against the background of a hyperechoic fatty pancreas. But the colleague is certainly very right. It's not always that easy.
Yeah, we're running out of time, but I have a last question for you, Schalk. We know that the drawback of the linear EUS is visualization of the right liver lobe. What about the perihilar lesions, adenopathies, strictures? Is there any role for EUS? Can it really help us? We know that's a very difficult position to place your scope in order to visualize the hilum. What do you think?
I think that's a very, very good question. And I think it's very important to visualize the hilum in when there's suspected pathology, because if you, from the bulb again, if you tweak, you should be able to see the hilar structures actually very nicely. And by focusing on dilation of the bile duct until you see that there's a stricture, that may be very useful to direct your EUS FNA towards that structure. And also, if you see lymph nodes in that area, you may be able to sample not the primary lesion, but the lymph node, and still provide a tissue diagnosis. We know that in the published series, the usefulness of EUS in that setting is about 50 to 60% diagnostic accuracy. But I think with the newer generation scopes, these are old studies performed by Marco Bruno still in Rotterdam. I think with the newer endoscopes, more if you take your time, your diagnostic accuracy should certainly be higher. So this is certainly an indication to perform EUS of that region and really have a good look and identify the structures, because you can from that area see hypoechoic lesions. And then finally, if you see a lymph node, that may be very useful, because that may provide you the tissue diagnosis, even though you haven't been able to reach the mass in the liver.
Thank you so much, Schalk. I think that this was for time being. I think we had a very, very interesting discussion, 2 excellent presentations, more than 500 participants, and I think that was a big success. I would like to thank both of you for being here this evening. And we would like to share with our audience some housekeeping slides. Remember that we are now, you can submit your applications for the ESGE research grants. Application will remain open till the 15th of November. Please do not lose the chance to apply. Of course, be sure to be with us in Berlin in April for the Jubilee of ESGE Days 2024, 60 years of ESGE. And of course, in order to do that, we'd like to actively participate. And for this, we'd like to ask you to submit your abstracts for evaluation. Abstract submission is now open and will remain open for a couple of months. And I would like once again to thank all of you for being here with us this evening. And we will see all of you in the next webinar that will take place in about 1 month, and will be about gastrointestinal subepithelial lesions in collaboration with the Korean Society of Gastrointestinal Endoscopy. Once again, a big thank to the ESGE Governing Board for taking care of this fantastic webinar series program, and a special thank to David Inker and Gabriela Varga for hosting us today. Thank you guys, and have a nice and pleasant evening.
Thank you.
Thank you.